We then took that into a more complex study where we wanted to use it in combination with different standard treatment modalities. So this was a phase 1 study of 3 different combinations. 2 of them meant for patients that are unfit for more aggressive chemotherapy. 1 in combination with low-dose RC, the other one in combination with decitabine. And then the third arm was for patients who were more fit to receive standard chemotherapy, so in combination with 3+7. In those studies, we established the safety and the tolerability of these combinations. We did see some of the known adverse events of these family of drugs. The taste is affected, and with that, the appetite goes down, and there's fatigue, there's muscle cramps. But it was much better than we have seen with other drugs that have been tested in this setting. So it was actually possible for patients to continue treatment for many cycles. And very few of these adverse events were grade 3. So we were able to deliver the full dose without any major problems. And we did see some activity. The response rate in the fit population was about 55% in the older than 60-year-old patients. In the unfit patients, the responses were lower, but there was activity that was seen with the combination. So then that led to the more interesting part of this study, which was the expansion cohorts. And for the low-dose RSC combination, which was the one of the 2 for unfit patients that was taken forward, we designed a randomized study of low-dose RSC alone or in combination with Glasdegib, with the primary endpoint there being to improve survival. And what we've shown is that there was actually a significant improvement in the survival, almost a doubling of the survival. With the low-dose RSC, it was about 4.8 months. With the Glasdegib, was about 9 months. And these curves continue separated. They don't merge at any point during the follow-up of the study. So a very significant improvement. And that improvement was seen both in patients with the lower and intermediate risk cytogenetic categories and in the high-risk cytogenetic categories. There was also an improvement in response rates, as you would expect, but most important was that survival benefit. And safety-wise, again, we saw these adverse events that you see with these kind of drugs, but nothing significant that did not allow the patients to continue on treatment. And then for the other study, for the we expanded the cohort of the patients fit for chemotherapy in combination with 3+7, but that was a single-arm study. It was a large study, about 70 patients that were treated, and we had a good response rate, 55% response rate, and we had the survival was according to the ELN cytogenetic classification, so better for the low risk and then the intermediate and then the high risk. And because this was a single arm, we compared to the historical data that's been published by the ELN, by these risk categories. And the survival that we saw in this patient population, patients over 60, was probably better than what has been reported. Of course, that's historical control and it has to be confirmed, but it appeared to be that there would be a benefit. So with that, there has been a design of a study that's just starting now, randomized, one of 3+7 alone or in combination with Glasdegib, and the other one is for unfit patients with hypomethylating agents, azacitidine, alone or in combination with Glasdegib. I do see these combinations potentially becoming standard therapy. It does appear that they have benefit. In one of the studies, we have a randomized study that shows an improvement in survival. I think that it is very possible that we will see an improvement in both of these arms, if not so much in terms of the remission, in terms of the remission duration and the overall survival. So that will make them standard. Of course, there are other new therapies coming, but I do think that this is a drug that could potentially add to some of the other investigational agents that are coming. These, for obvious reasons, you have to start with just combinations with the standard therapy. And I think it'll add there, as I mentioned earlier, add particularly in the survival. But I think it has the potential to add also to some of the newer drugs that are coming along.